Hi, I'm Dr. Mata. I'm a pediatric cardiologist working at Norton Children's Hospital. Thank you, Cindy. And University of Louisville. As you can see, I don't have any financial disclosures. So today we are going to talk about the metabolic syndrome, definition, prevalence, risk factors, pathophysiology, screening, and management. So we are going to talk a little bit about the comparison between the pediatrics and the adults because whatever happens in the pediatrics continues into the adulthood. And as Dr. Bowling said, it is a chronic disease. Obesity is a chronic disease leading to the, in sometimes to metabolic syndrome. So I just want a little bit of comparable statistics. It is also called insulin resistance syndrome or syndrome X. And to define metabolic syndrome, you have to have 3 out of 5 factors. One is abdominal obesity. So we do have AAP growth charts for waist circumference. And if it is more than 90th percentile for age and gender, so that is one of the factors. Second one is HDL less than 40. Triglycerides more than 150, and systolic blood pressure more than 90th percentile for gender, age, and height, because this is all age and height and gender specific. So that's why we cannot just throw a number like, oh, more than 130 or something like that. And the last one, but not least, is the fasting blood glucose more than 100. Whereas in adults, so the definitions are given by 2 federations. One is the National Cholesterol Education Panel, and the other one is the International Diabetic Federation. So there are no significant major changes, except that the abdominal obesity in case of men, it should be more than 40 inches. And in women, it should be more than 35 inches. Whereas in the Diabetic Federation, it is slightly less. So, but otherwise, as you can see, triglycerides more than 150, HDL in men less than 40, and in women less than 50, and blood pressures more than 130. They're all kind of similar. So main thing is just the abdominal obesity. So what is the prevalence? So these are unfortunately pre-COVID statistics. So prevalence of metabolic syndrome in children is about 9 to 10%. So that's a lot. And we don't even think about metabolic syndrome until recently. And pre-COVID, the obesity rate is like, 18%, but now statistics are saying, anywhere from 22 to 25%, depending on the state. And, almost half of the obese children are having a metabolic syndrome. Again, I'm going to repeat that half of the obese children have metabolic syndrome. Whereas in adults, there is the 35% metabolic syndrome. So, and the obesity, again, this is pre-COVID, about 40%. That means almost all obese adults have metabolic syndrome, or at least 90th percentile adults have, obese adults have metabolic syndrome. Coming to racial differences, so obesity is more common in Hispanics and Blacks more than the whites. And dyslipidemia is more seen in Hispanics more than Blacks and whites. And in Blacks, there is increased incidence of hyperglycemia, so diabetes. So these are all statistics, but Blacks do have diabetes, which is another horrible disease. So these are all just statistics. It doesn't mean, these patients don't suffer in long term. So in my mind, I think they're all kind of same, have the same risk. But for the statistic purposes, increased diabetes and increased hypertension and decreased dyslipidemia in Blacks. So in Native Americans, they have the highest prevalence of metabolic syndrome, almost 20%. So 1 out of 5 children meet the criteria for metabolic syndrome. That's a lot. Whereas in Hispanics, it is about 13%, in whites, it is about 11%, and in Blacks have the lowest prevalence of metabolic syndrome with 3%. But again, remember, they have the highest prevalence of diabetes. 90% of newly diagnosed type 2 diabetes meet the criteria for metabolic syndrome. So always be watchful when you see the patient with the type 2 diabetes. So there is a AAP provided risk factor clustering of metabolic syndrome, ethnicity, as we discussed in the previous slide, maternal gestational diabetes, low birth weight, short duration of sleep, actually because of the inflammation and oxidative stress, excessive screen time, low physical activity, lack of whole grain and fiber intake. So whatever can cause obesity, it can be exogenous, like whatever they say here, or endocrine, or kidney diseases, or medications, anything that can cause obesity, you need to be watching out for the metabolic syndrome. Otherwise, family history of obesity. If a parent is obese, child is twice likely to be obese. Parent or grandparent with premature cardiovascular disease, parent with a total cholesterol more than 240. This is the risk factor clustering for metabolic syndrome. Just continuing the risk factors, childhood obesity, again, pre-COVID, it was 18%. I didn't make the changes because I just want to understand. I don't have the metabolic syndrome statistics yet, post-COVID or intra-COVID, probably, I should say. So I just kept the previous statistics as it is. Pre-hypertension or hypertension is seen anywhere from 8 to 14, depending on the several studies. Dyslipidemia is seen in 20%, that is 1 in 5 children. So generally, low HDL is seen in the 6%, and pre-diabetes or diabetes is seen in 15%. As you can see, almost hypertension, dyslipidemia, and diabetes almost equal to the obese patients. So coming to the pathophysiology. So we know that pathophysiology is starting in the childhood. I will go over in the next few slides. So there are two things happening. One is, of course, both of them are happening in the liver. One is on the glucose metabolism, and the other one is on the lipid metabolism. So going to the glucose metabolism, suppression of hepatic glucose production is impaired. It is kind of a confusing term, but in the liver, generally, insulin helps with the suppression of the hepatic glucose production, and in the insulin resistant stage, that is gone. Whereas the other one in the lipid metabolism, hepatic lipogenesis is not impaired. So glucose metabolism is impaired, whereas the lipogenesis is not impaired. So two bad things. So coming to the glucose side, in the insulin resistant state, there is increased hepatic glucose production, increased glucose output. So there is a lot of glucose in the blood, but there is increased muscle insulin resistance. So muscles can't use the insulin. So glucose is just sitting there in the blood, and decreased glucose disposal. On the other side, in the lipid profile side, insulin resistant state. So because hepatic lipogenesis is not impaired, there is increased free fatty acids, there are increased triglycerides into circulation, and low HDL and adipose deposition in liver and arteries. So this is the beginning of what can happen later. So in the beginning of the metabolic syndrome, these are the states that happen: pro-inflammatory state, pro-thrombotic state. So all the nice things for the development of the atherosclerosis. So in the pro-inflammatory state, there is increased high sensitivity CRP, increased inflammatory cytokines, TNF-alpha and interleukin-6. Now with the COVID, we all know a lot more about interleukin-6. And there is decreased adiponectin levels. So in case of prothrombotic state, we already know that there is increased antifibrinolytic factors like PAI1 and increased fibrinogen. And as if these two are not enough, there is vascular dysfunction leading to, with endothelial dysfunction leading to microalbuminuria. So people are actually doing the research on the value of measurement or treatment of these inflammatory or vascular function markers in the setting of metabolic syndrome, but we don't know the value yet. But in adults, adult cardiologists use the elevated levels of hsCRP as a predictor of the CVP. So they also use it as a prognostic factor. So they already started using that in adult cardiology. And these atherosclerotic vascular changes actually begin early in the childhood. How do we know? We do know that there is increased carotid artery intima and media thickness on carotid ultrasound. There is that means there is at risk for the stroke or TIA to begin with, TIA and stroke. And then there is decreased reactivity on the brachial artery, that is, beginning of the peripheral vascular disease. And there is increased arterial stiffness, leading to diastolic dysfunction later, diastolic hypertension and diastolic dysfunction later. Process is accelerated because of the presence of risk factors, but can be minimized or even prevented with adherence to a healthy lifestyle. So yeah, we talked about it. So like, why should I care, right? So we know that pathophysiological changes start in childhood, leading to premature cardiovascular disease. So what is cardiovascular disease? So it includes three components: coronary artery disease and stroke or TIA and the peripheral vascular disease. So, and about 600,000 people die of cardiovascular disease every year. That is 1 in every 4 deaths. And out of those 600, about 370,000 are because of the coronary artery disease. So 1 in every 4 deaths are because of the cardiovascular disease. And so why is it important in metabolic syndrome? In metabolic syndrome patients, they have 3 times risk of getting the cardiovascular disease and 2 times, cardiac death with the CVD. So that's why this is important. That's why, we need more, counseling and, starting prevention right from the childhood. As of 2018, about 16.5 million people over the age of 20 have coronary artery disease. So we are interested in premature cardiovascular disease. As I told my patients and their families, of course, we all have to die at some point, but we shouldn't be dying before 60, 70 years of age, right? So at least if it is a preventable disease, we should prevent it. So what is premature cardiovascular disease? Having a CVD in men less than 55 and in female less than 65. 55 and 65. So most of the people on this conference fall into that. So we shouldn't be having the premature CVD. And premature incidence in less than 40-year-olds is 10 to 11%. So as you can see on the graph on the side, so 20 to 40-year-olds in men, it is about 12%. And in females think that, oh, we are kind of immune to this. No, not really. So it is common in 10%. And if you can see 40 to 60-year-olds in men, it is about 40. Again, most of us fall into this. So, it is called premature cardiovascular disease and it shouldn't happen. So that's why I'm really interested in, and what is the reason for this? Mostly metabolic syndrome, mostly. There are some other reasons for the premature cardiovascular disease, but mostly metabolic syndrome. So obesity leading to metabolic syndrome, family history of early CVD, of course, patient with familial hypercholesteremia, so that's a separate entity. And smoking, anything with the smoking, any kind of risk factor with smoking almost doubles the risk of having the CVD. Diabetes and secondary causes like kidney diseases, endocrine diseases, liver diseases, all those. So adult cardiologists use this atherosclerotic cardiovascular disease risk estimator, so kind of Framingham risk estimator kind of thing. What it does is we plug in all this information like a current age, sex, race, your systolic and diastolic blood pressure, total cholesterol, HDL, LDL, whether you have history of diabetes or not, whether you are a smoker or not. And we plug it in, and actually it is easily available on mobile phones and it is available on Google. So you can actually easily Google it. And it spits out once you plug in the information, it spits out what is the risk of you having, let us say I'm a 40-year-old and I plug in all that information, and it gives me risk of me having a cardiovascular disease in next 10 years. So obviously it gives as like, if it is less than 5%, it is low risk, borderline, and intermediate 5 to 20, and high risk is more than 20. So let us say generally dyslipidemia is, it falls between, depending on the age and everything, it falls between low risk and borderline, but add it with the smoking, it goes into the intermediate risk just like that. Smoking and diabetes are the worst combination. And what are the other associations? So metabolic syndrome is also associated with the fatty liver disease. It is called non-alcoholic liver disease, and like steatosis, fibrosis, and cirrhosis. And it is also associated with polycystic ovarian syndrome. So these are the girls with obesity, hirsutism, and insulin resistance. So they have high incidence of metabolic syndrome. So gynecologists and pediatricians should be aware of keeping an eye for metabolic syndrome. And obstructive sleep apnea and pseudotumor cerebri. In adults, it is actually associated with a lot of cancers, but most commonly hepatocellular carcinoma and intrahepatic cholangiocarcinoma, chronic kidney disease, hyperuricemia and gout, and dementia. So how are we going to screen for dyslipidemia? There are two, AAP actually recommends two universal screening of all children, whether they have the risk factors or not. So the first one should be 9 to 11, and the second one should be between 17 and 21 before we discharge the patients from the pediatric service. Okay, so whether they have the risk factors or not, we need to get these two. Let us say they have the risk factors like parents with homozygous familial hypercholesterolemia, or both the parents are heterozygous, then you need to check from birth to 2 years. And between 2 and 8 years, let us say positive family history of cardiovascular disease. If patient has diabetes or chronic kidney disease or heart transplant or Kawasaki with aneurysms, and even if it is normal, repeat every 2 years thereafter. And 12 to 16, we generally don't recommend it. You can get it, but if it is negative, it doesn't mean anything. Of course, if it is positive, you can treat it, but false negatives are very common. And then most of the pediatricians do ask me, what type? Is it like a fasting lipid profile and non-fasting lipid profile? But if you're going to see a patient at 2 p.m., we are not going to bring them fasting. So you can always get whatever that is available at that time. And finger stick versus venipuncture, it really doesn't matter. It is not statistically significant, so nothing to worry about it. And if the initial test is abnormal, repeat the fasting lipid profile in 2 weeks to 3 months, depending on the levels. But decisions about pharmacological therapy should always be based on the fasting lipid profile. I just want to throw out this one. LDL-C can be quantitated directly or indirectly. And in the lipid profile, we generally see is the indirect LDL, and this is how they calculate. LDL is the atherogenic cholesterol, so that is equal to total cholesterol minus non-atherogenic HDL minus atherogenic VLDL. VLDL is nothing but triglycerides divided by 5. So that's why it is indirect measurement. But if the triglycerides are more than 400, actually the test may say, we cannot measure or something like that. So the reason is because of the triglycerides. So you can always get you can always order the LDL, direct LDL. Pediatric hypertension, blood pressure chart, AAP have blood pressure charts for the age, gender, and height, and we always have to get the manual BP. Of course, most of us sometimes use the automated, but if it is abnormal, definitely get the manual BP. And normal is less than 90th percentile, and pre-hypertension is 90th to 95th percentile. Obviously, we need to go through the lifestyle modifications, repeat the blood pressures in 6 months, and try to get the 4 extremity blood pressures at the time. And if blood pressure is still high after 1 year, refer to subspecialists. Stage 1, 95th to 99th percentile plus 5 mmHg. I mean, all these numbers are a little bit iffy, meaning that it changes, right? Like 5 to 8 mmHg plus or minus, it always happens. So, but these are the ones that, in the studies and recommendations. Recheck the blood pressure in 1 to 2 weeks manually, and again for extremity blood pressures. Lifestyle modifications, recheck blood pressure in 3 months, and if blood pressure is still high, refer to subspecialists. Stage 2, more than 99th percentile and 5 mm Hg, check the 4 extremity blood pressures, because these are the patients may have coarctation, so you have to be careful. So repeat the blood pressure in 1 week or directly refer to subspecialists. So how do we prevent? So again, lifestyle modifications, especially major culprit in the young children is the fruit juice. So, and Dr. Bowling already went through the diets, so I'm not going to go over it, but Mediterranean and DASH diets, especially daily sodium intake less than 2.4 grams, or actually less than, we actually try to 1.8 to 2 grams, depending on other things. High fiber diet also is important. I actually tell my families, just do something rather than arguing about and discussing about all these things. Have some interest in, I actually encourage them, okay, so if you want to do that, go with it. They always ask me ketogenic diet. I'm like, okay, go with it. That means they're actually focusing on it. That is more important for me rather than, discussing about olive oil versus coconut oil versus canola oil. I'm not going to get into that. I tell them, unless you are deep frying, just use whatever you want, whatever you are comfortable. So daily minimum of 30 minutes of moderate intensity, such as brisk walking, and healthy sleep habits and limiting screen time. So mostly dietary, and physical activity, good sleep habits, and stress reduction. So I also talk about yoga and meditation and all that. So most of these kids have depression or anxiety. So sometimes I refer them to psychiatry for further evaluation. So appropriate restriction of calories is important, and involving the whole family and community in prevention efforts is important. And school-based programs and community engagement, and a multidisciplinary approach like dietitians, mental health practitioners, providers, and nurses. Again, coming to the diets, Mediterranean DASH diet, and vegetarian or vegan and plant-based. So these are the important ones. So there are many obstacles to healthy eating and weight management, like living situation and limited food budget. So, to get to buy a salad, it may cost like $3 to $4, whereas mac chicken is $1. I mean, I'm a big fan of mac chicken, but people tend to go towards the least expensive food, parents' work schedule, readiness to change, and parents feel guilty to make any changes. So actually, one of my parents, father passed away, so mother feels very guilty, stopping it. And my patient is 12-year-old who is weighing about 350 pounds. So and busy schedule. So sometimes these families have like 2 shifts, and so and mom or dad, single parent families, and they come in the middle of the night, so they don't have any energy to cook, or so they just buy the fast food, and or keep the freezer full. So all these things are bad. So then they're picky eating, so they try to give it to whatever they eat. And especially in the autism patients nowadays, there is a lot of concern about that too. So treatment, I'm not going to get into too much with the medications, because Dr. Bowling already went through it. So behavioral and pharmacotherapeutic interventions, metformin and orlistat, generally these are very short-term, but you may really bounce back, so really not helpful. Hypertriglyceridemia, high-dose fish oil, fibrates, niacin, and high-dose statins. Hypercholesterolemia, statins, hypertension, ACE inhibitors, and calcium channel blockers are preferable. Bariatric surgery, obviously, if the BMI is more than 40, and we don't need to have any other comorbidities, but generally they do. That is one of the criteria. And the second one is BMI of 35 to 40. They have to have other comorbidities like type 2 diabetes, severe sleep apnea, pseudotumor cerebri, fatty liver. And we generally do it more than 12-year-olds. So So we do have this metabolic syndrome clinic, and we actually, this is the last slide actually. So I'm going to leave it like that. We started in February of 2017. We were actually making a lot of progress before the COVID hit. So one pandemic fighting with the other pandemic. Actually, they are not fighting, they're actually working together. So, so the obesity and metabolic syndrome actually getting worse. And all these patients, they are supposed to lose weight, and they actually, few of my patients gained actually 60 to 70 pounds, even more, so it's really sad. So the criteria are the referrals to this clinic or dyslipidemia, hypertension, even the family history of cardiovascular disease and or sudden cardiac death, because I want to counsel all these patients. And morbid obesity, if family is considering bariatric surgery. And of course, again, the goal of this clinic is start screening and counseling early for long-term goal of good cardiovascular health. And we have 2 MDs now, and a registered nurse and a dietitian. We actually send several referrals to endocrinology, sleep medicine, nephrology, GI, neurology, psychiatry, and bariatric surgery. I just want you to know in the bottom one, presence of one component of metabolic syndrome should lead to evaluation for other risk factors. So I'm open for any other concerns, and thank you for this opportunity.
Thank you, Dr. Mata. That was a great talk. Very interesting and enlightening.